Hi, this is Alan Gardner again with part two of this two-part series on pharmacology of pain. In this session, we're going to be looking at opioids and some applied pharmacokinetics. By the end of this session, we will have explored the mechanism of action of opioid analgesia, and I'm specifically using the term opioid because you're probably familiar with the term opiates, whereas opioid is the term that encompasses both naturally occurring opium-like chemicals and synthetic chemicals that are similar as well. So, for example, morphine is a naturally occurring opiate, whereas fentanyl is synthetic, therefore only found when it's produced in laboratories. So opioid is the more sort of catch-all term here. We'll also be looking at some applied principles of pharmacokinetics, looking at two key analgesics. In particular, we're going to look at codeine and morphine. Similar to in part one, I'm aware that you've already looked at the physiology of the nervous system in relation to how we perceive pain, but we did look over some of the peripheral physiology in part one. Now we're just going to do a brief revisiting or revision of the physiology of the central nervous system and how that plays a role in our perception of pain. So we can pick this up again from the dorsal root ganglion, which is here. Last time we said that there was this noxious stimulus and it traveled along this nerve fiber to the dorsal root ganglion. We then have a synapse with a second order neuron here which decussates in this direction, and it's going to travel up our spinothalamic tract, up the spinal column. So our spinothalamic tract is the distinct pathway up the spinal column that transmits pain signals, and it also transmits some sensation of touch as well. Excuse me. So this travels up the spinal column and through the brain stem, where it's processed within the thalamus and the sensory cortex. This is where we actually now perceive pain. So everything up to this point was purely a neurological signal, and now this is where we actually start to perceive pain. Now we said that there were two distinct pathways via the A delta fibers, also the C fibers. Now our A delta fibers, they have this second order neuron in the dorsal horn, and then it travels up our spinothalamic tract toward the thalamus. Our C fiber is a little different, that also connects to our limbic system here, which is where we process emotion. So the not only are there differences between A delta fibers and C fibers in terms of the speed at which they transmit signals, but also our C fibers have a distinct pathway that allows us to associate emotion with pain, which is why people who suffer pain over a period of time will experience a negative emotional connotation to pain. Essentially, this is why chronic pain sufferers tend to be more at risk of developing depression and other experiences of low mood. Now, we know that pain is useful in terms of our survival, that if we experience something as painful, it teaches us to avoid that situation or stimulus. It also can lead to us removing ourselves from any sort of stimuli that produces pain. However, we also know that there is a survival benefit to being able to switch pain off. If we consider our ancestors who will have needed to remove themselves from dangerous situations, even if they were experiencing pain, perhaps from a damaged limb, for example. That there's a survival benefit for being able to downgrade our experience of pain, albeit through a temporary measure, in order for us to survive a particular situation and then deal with the injury and the consequences at a later date. Now, in our modern lives, this is perhaps less common, and so it might seem less relevant, but in terms of kind of a more contemporary example, we usually see this through sports. So, for example, assessing someone who's had an ankle injury during sport, that one of the things we know is that people can play through ankle injuries and think that everything's okay until say the game of rugby, for example, that they might be able to continue playing, and it's only after the end of the game that they realize, oh, actually my ankle's quite sore, and now I can't weight bear on it, and so I'm going to go and seek help from it. And the way that our bodies are able to do this is through these descending inhibitory pathways. And if we look at this diagram on the right, we'll see that our descending pathway is expressed here as this green arrow that I'm just following. So what we can see on this diagram then is that we can see our usual pain pathways from nociceptors toward the dorsal horn in this direction, and that we have our synapse here. So I'll just write synapse. Okay. So we've got a synapse there, and this green neuron is traveling down from the hypothalamus here. So this part of the brain that's depicted here is the hypothalamus, then travels through the brain stem, which is made up of our midbrain, pons, and medulla, and it travels down a distinct pathway within the spinal cord called the dorsolateral tracts. So it travels down the dorsolateral tract, and it synapses with our pain neurons here within the spinal cord. On the next slide, we're going to look at this in a bit more detail. Here we have a close-up of our synapse. So we have our first order neuron here, where our pain signal is traveling in this direction. Ordinarily we would have our noxious stimulus that would send this wave of depolarization down the nerve fiber, where at the synapse we have a release of neurotransmitters such as substance P and glutamate that will travel across the synapse from the presynaptic knob to the postsynaptic knob, therefore continuing the transmission of pain signals toward the brain. However, with our descending inhibitory pathway, I'll draw this in green, we now have a neurological signal traveling down our inhibitory neuron, which is going to release its own neurotransmitters and flood the synapse with these, where they will bind to receptor sites, inhibiting the transmission of pain neurotransmitters, but we have both presynaptic inhibition here and postsynaptic inhibition here, and these neurotransmitters, I draw an arrow here, these are our body's own natural opioids. So these are chemicals such as endorphins and enkephalins, and these are going to inhibit the transmission of pain within the central nervous system. And this is exactly how opioid medication works, that it works by binding to these opioid receptor sites within the central nervous system to produce an analgesic effect. And you can see here from this list that we have 4 different opioid receptor types. We have the MOP or mu receptor, so you can see that they're sometimes represented by these Greek symbols. So the MOP, the mu receptor, this is the main one that we're thinking about, and we're going to talk a little bit about in a minute or two, whereas the other 3 are less relevant to us clinically. That we have our MOP or mu receptor sites, and these are widespread throughout the central nervous system. This includes the cerebral cortex, the basal ganglia, the spinal cord. So these are very widespread, and when we stimulate these receptors with opioid medication, that produces an analgesic effect, but it also produces a wide range of other side effects, such as respiratory depression. So this is why we see respiratory depression signs in our patients. So for example, when we administer intravenous morphine, we need to be monitoring our patients' respiratory rate and oxygen saturations because of the respiratory depression that we see as a result of stimulating these MOP receptors. We also see constipation due to a reduction in secretions and a reduction in peristalsis, and we see cardiovascular depression as well. With regard to the COP or kappa receptor, these are much less widespread throughout the central nervous system. There are some drugs that can stimulate the kappa receptors. Pentazocine, for example, is a partial kappa receptor agonist. And in comparison to the mu receptors, we see less respiratory depression, although it also produces less of an analgesic effect as well. The next one on the list is the DOP or delta receptor. Again, this is much less widespread throughout the central nervous system. And then we have the NOP or non-specific receptor, which there's less is known about this particular receptor. We do know that with low doses of drugs that affect this, that we see a hyperalgesic effect, so that will actually increase pain. And it's only with high doses of drugs that affect these that we'll see an analgesic effect. Moving on now to the pharmacokinetics of codeine. I was saying in the previous video that pharmacokinetics is the term used for the way that the body acts on a drug. So we've spent most of our time so far defining the mechanism of action of opioids, and this comes under the umbrella of pharmacodynamics, which is how the drug acts on the body. We're now moving on to think about, well, how does our body actually act on these chemicals once they've been administered. Codeine is interesting in terms of its pharmacokinetics because it's actually referred to as a prodrug. A prodrug is a chemical that, while it's administered, it has little to no therapeutic benefit until it undergoes metabolism. So I said in the last video that metabolism is the way that drug chemicals are broken down within the body, and that this is usually done within the liver. What we can see from this diagram is that morphine and codeine are chemically very similar. In fact, codeine is often referred to as methyl morphine. So what we have here is this methane group that's attached to the rest of the molecule, and as this undergoes one of these metabolic pathways, this methyl group is removed, which means that one of the metabolites of codeine is morphine itself. That's all I'm going to say about morphine for now, because actually on the next slide we'll look at morphine and its metabolites in a bit more detail. Whenever we ingest a medication via the oral route, it tends to undergo what we refer to as first pass metabolism. So this is the body's ability to divert chemicals that we ingest to the liver for metabolism prior to them entering the systemic circulation. And this tends to limit the amount of a drug that actually reaches the systemic circulation when it's administered via the oral route. Now, the amount of a drug that actually reaches the systemic circulation at initial ingestion is referred to as the bioavailability. So this is part of, in pharmacokinetics, what we refer to as distribution. So bioavailability is the proportion of an ingested or administered drug that ends up actually active within the systemic circulation. So codeine itself has a bioavailability of about 50% when administered orally. In addition to that, about 5 to 15% of codeine is eliminated unchanged in the urine. The rest of the administered dose undergoes one of these 3 metabolic pathways that we see here. So, however, of these 3 pathways, the clinically most effective route is through the metabolism to morphine and its and its metabolites. As I'm sure you're all aware, morphine can be administered in a number of different ways, including oral administration. It can be injected either into the subcutaneous or via the intramuscular route, or it can be administered intravenously. With regard to the oral administration of morphine, this has a bioavailability of only 30%. So in the previous slide, I mentioned this idea of bioavailability, that this is the proportion of an administered drug that actually becomes available in the systemic circulation. So it's quite a dramatic decrease down to 30%. And this is due to the other idea I introduced, which is hepatic first pass metabolism. So that's when the administered drug is diverted from the gastrointestinal tract through the liver, and it's metabolized before it reaches the systemic circulation. And if we compare that to the intravenous route, where we have 100% bioavailability, then we can start to appreciate that why we see such a dramatic difference in the clinical efficacy of the 2 different routes, that we have 100% bioavailability through the intravenous route, and therefore we see a much more dramatic effect on our patients. The intravenous route reaches its peak effectiveness after about 10 minutes and has a duration of action of about 3 to 4 hours. Morphine is metabolized primarily in the liver, although a small amount is metabolized in the kidneys, and it's metabolized through these 2 pathways that we can see here. Now it says 90% in the on this diagram here. I've also seen sources that say about 70% is metabolized through this pathway here to this, which is morphine 3-gluconoride. The other main metabolite of morphine is this morphine 6-gluconoride. Now this makes up a smaller proportion. Again, this says, the diagram says 10%. I've seen other sources that say about 30%. Interestingly, this metabolite of morphine, this morphine 6-gluconoride, is actually much more potent, up to about 13 times more potent than morphine, and it has a similar duration of action. So what that means is that although we're injecting or administering morphine directly, that actually it has what we refer to as active metabolites. So as our body breaks down a drug into new components, we refer to those as metabolites, and if they themselves have an active therapeutic effect, then they are referred to as an active metabolite, which helps to prolong the duration of action. But sort of turning that on its head, we think about, well, what about the side effects? So if we see undesirable respiratory depression, undesirable cardiovascular depression, that's going to be prolonged because our metabolites themselves are active. So as our body is trying to break down morphine into its constituent parts ready to be eliminated, that we also have activity produced by its metabolites. Both of these metabolites are excreted by the kidneys, but there's the potential there for them to accumulate in patients with renal failure. That brings us to the end of this two-part series on pharmacology and relating that to analgesics. I really hope that these two videos have been useful. Please feel free to leave some comments if you'd like to see something change in the future, or anything that if you have any questions, for example. And thank you very much for watching. Hopefully I'll see you soon.